All right, so good evening. Welcome to the virtual tumor board session. Today, we have the pleasure of having an fantastic expert panel. Our good friends, Dr. Edward Diaz from MD Anderson and Dr. Michael Hinney from Mayo, Arizona. They really need no introduction. They are supreme experts when it comes to larynx and head and neck oncology. I'm hoping that Dr. Gilbert will join us. We are going to talk about the larynx and the larynx diseases. So our first presenter is Dr. Vulia, is it Vaititis?
Yep, Vaititis.
Vaititis from LSU. Well, you have to start.
Yeah, all right, thanks for having me today. I work at LSU now. I just finished fellowship in June, so I know how you all are feeling your time. I'm gonna present a case on RR, 78-year-old female who presented to the ER and saw one of my partners with a 3-week history of stridor in the middle of the night. She has a past medical history of acute coronary syndrome, hypertension, and peripheral vascular disease with a right-sided AKA. On exam, she has biphasic stridor and severe dysphonia. Next, I have a video for scope exam.
Okay, relax. Breathe in. Okay, all right.
Okay.
Let's
Let's just stop. Yeah, let's just stop here. So let me ask our expert panel, Dr. Hinney. Usually these cases show up Friday night when everybody's trying to leave. How would you approach, what would you tell your residents and your team how to assess these patients, what to do, what not to do?
Smoker? I didn't get
Yes.
that. Maybe I missed it.
Yes.
Yeah. So, I mean, generally it's 1 in.the morning, and the resident's on the phone. I used to, I wonder why we got away from this, have a bracket that would attach to a laryngoscope, and I could actually watch this exam in real time. That sure beats coming in and repeating it. So I'd encourage you to, look into that technology. We live in a virtual world now, and might as well, make it easy. So this lady, she's been stridorous for 3 weeks. So that's, this is a tumor until proven otherwise. Can she lay down, or because as people lose their airway, bad sign is they start sleeping upright. And when they sit in the ER chair and say, I've been sleeping in a chair the last few nights, they're in trouble and probably need an airway tonight. So that's my first thought.
Sure.
Yeah, she was more comfortable sitting up, but actually did do okay laying pretty flat.
So then you ship her over to the CT scan and let's see how bad this is.
Okay.
I would not
Dr. Diaz.
encourage the resident to make a biopsy laryngoscopically in the ER for fear of taking a bad airway and making it worse.
Yeah, I agree.
Wise words indeed. Yeah.
I agree. I would only stress to be cautious about that CT scan because, and you've alluded to it, the patients laying down, they can't have secretions. I don't know if this was the whole video, but that patient needs a trach. So it's just a question of before or after the CT scan. The CT scan would be nice because if you can know what you're looking at, maybe know where to get a biopsy. So while you're in there, get a biopsy. And the only thing I would add to all that is I was so glad to not hear you say that saturation was 97% or 98%. I get so upset when I hear a resident say, well, the patient's okay because their stat was 98%. And what I say is, what's your saturation now? Put your hand over your mouth. What is it now? You can go from 100% to critical with obstruction. So saturation is not a good thing to base someone's airway on. It's how they're breathing. Like Mike said, are they sitting up? Are they bobbing back and forth? Are they drooling? If any of those things are present, trach in the OR if possible, or bedside if needed, CT scan and biopsy eventually.
Here, here.
Very good. Okay. Well, continue.
All right. So we ended up taking her to the operating room, and we were lucky enough that we were able to fiber optically intubate her and get a trach and biopsies. And then we did the scans afterwards. So here's her CT, her axial images. I know they're just video clips, not everybody can scroll through, but you can see she's got a lot of paraglottic and preepiglottic extension. Her thyroid cartilage was actually preserved. Thankfully, our trach is below tumor. And then this one shows a lot of the preepiglottic extension in that.
Okay. And do you have any or any bone windows to look at the cartilage?
I should, I don't, not easily pull up, I'm sorry, but the cartilage was intact.
Got it. All right. Well, okay. So, and I see Dr. McCammon also joined us. Thank you, Suzanne, for joining. Dr. Diaz, so tiny little tumor, you can barely see it. Nothing really to worry about. What would you do? How would you recommend to this woman?
Yeah, clearly, tiny little tumor. So the Anderson way is, this patient would have to get a biopsy. I assume you did a biopsy. And did you tell us what it was? Squame.
Squamous cell carcinoma.
Yeah.
Yes.
So, we have this patient see med-onc, rad-onc, speech, dental, all those things. But to make a long story short, I don't know if this patient is a really good candidate for conservation anything. That's the teaching at Anderson. We think that if the larynx doesn't work well before radiation therapy, they're not likely to work well after radiation therapy. So that tends to be our bias. Now, that said, committing someone to a total laryngectomy is a pretty bad thing. And if a patient's willing to try induction, we might give them induction. If they have a great response, then maybe try radiation therapy. But I'm looking at this patient, it's a T4, I didn't look at the notes, but it's at least a T4 laryngeal cancer. I think, total laryngectomy is in their future.
Okay.
Either for
great.
function or for disease.
Couple of questions. So sometimes you have these bulky tumors and the CT says the cartilage is intact. Would you ever get an MRI for these things?
Never say never, right? So yeah, we sometimes would, but our guys especially, they don't tend to rely MRI. It doesn't tend to be that subtle. We don't worry about microscopic invasion of laryngeal cartilage. So if it's something that's so subtle that you need an MRI to see, then I would just say that it's not there and treat it as it's not there. And that would open up many more options in terms of conservation with chemo RT stay. If it's obvious, if you've got big bad thyroid cartilage invasion, then those are the patients that are going to get chondroradial necrosis with RT and their function's bad. So I would say probably as a rule not, but I've seen plenty of patients that did get MRIs for the thyroid cartilage.
Sure.
It doesn't tend to be that final line for us.
Yeah. Dr. Haney, you're known to be able to do a total laryngectomy endoscopically. I just made that up, but what would you do for this patient? What would you recommend?
Oh, I agree with Ed pretty much down the line. So organ preservation therapy generally doesn't or never actually takes a non-functioning organ and makes it functional. I think this, I trust the read from the head and neck radiologist that there's not bone involvement, but it sure looks like in the picture I'm looking at that there's tumor coming out into strap muscles in the thyrohyoid space.
Yeah,
It's a big tumor, and inferiorly you can see that there's cricoid involvement. This is not a I don't have a conservation operation, endoscopic or open, for this. And that notwithstanding, a 78-year-old that has a large resection, conservation resection that takes an arytenoid out, they're going to aspirate like crazy. So in this center, this patient would get a total laryngectomy and bilateral neck dissections, and perhaps adjuvant radiation at least, depending on the pathology findings.
Great.
Yeah, Mike, I agree.
Thank you so much.
I think you can debate the subtleties of T4s about what to do, but this isn't a subtle one. I think you're completely right.
So just to reiterate, there's nothing wrong with upfront total laryngectomy. And then also we talked about maybe induction. Now this patient already has an AKA, you said, or BKA?
Correct, and above knee on one side.
And that's because of atherosclerosis or traumatic?
Atherosclerosis.
Okay, so as you know, if the heart is that bad that needs that peripheral vascular disease, I don't know how much they can tolerate high dose cisplatin or TPF. That's another thing that's going against it. Okay, so Dr. McCammon, how would you consult this patient about, comes up to the hospital and suddenly says, oh, you need your larynx out? This is not an easy pill to swallow.
No, it's not. And I think that, I agree with everything that Dr. Diaz has said. If the larynx is not working now, it's not going to work after chemoradiation. And one of the strategies I use in talking to these patients is to say, look, the cancer has already taken this function, and if it hasn't taken it now, it will in the future. And so I try to think in terms of function, and then I try to talk to them explicitly about the visual stigma of the laryngectomy stoma, because I find that that's one of the main things that patients have trouble with. This is not a one-time conversation. This is usually a conversation over a couple of days. And there are some patients who will get on board right away, and some patients who are never going to, and who will not accept a laryngectomy until they've exhausted what they perceive as every other option. So,
Susan, those are great points. Telling the patient and the family that the larynx is already gone can really be helpful. And we're going to try and get you to where you can breathe again and eat again.
Yep.
Fantastic. Great. Okay.
A question for the panel. When you do your assessment for laryngeal function, this case, I think, is a little bit more on the presenting to ER situation, but sometimes patients present a little bit less in extremis. Can you just comment on some of the parameters you look at to help you assess laryngeal function? Do you have all your patients see speech? Do you look at weight loss? Do you, are there clinical evidence of aspiration or fees or MBS? I'd be interested to hear some of the details about, laryngeal function. I think we can agree is an important parameter, but I'm interested to see what are the kind of data points some of the experts use to make that assessment in order to have a meaningful discussion.
Yeah, we, Jeff, that's a great question. At Anderson, if we're considering, well, anybody, whether we're leaning towards RT or surgery or whatever, they're all going to see speech path. And that'll include video strobe, almost always fees, and a formal modified barium swallow. Things like weight loss and stuff is a little bit more difficult to quantify. When it's obvious, it's obvious. A 5 or 10 pound weight loss may be significant, or maybe because they've got cancer and feel like crap. So speech path definitely plays a big role in helping us out. Definitely. This one's not a hard one, right? It's the ones where they're aspirating a little. And those are the patients that you have to all right, we can try conservation and it may be bad and we end up doing a laryngectomy later, which I have no problem with. Or you say, listen, I think, Susan, you were kind of alluding to this. I spent a lot of time telling patients, total laryngectomy is not as bad as they think. It's usually, not usually, but in many cases, it's the quickest road back to recovery. And so counseling, secure your airway, get the diagnosis, and then counsel, and find out what's best for that particular patient.
Great point. Thank you.
Yeah, it's the same
okay,
here.
Bill, yeah. Go ahead, please.
Yeah, it's the same here. And in my opinion, we don't do enough total laryngectomies in this country anymore. And starting with Kristen Gorin and many others have confirmed that a patient like this has a significantly improved survival rate if they get an operation. And best guess is more than a guess, I guess. It's about 10% improvement in overall survival. And the treatment is less expensive. So it's this, I agree, this is a pretty straightforward, more easier one. And the tougher ones are where conservation surgery is an option. And this is an older person, smoker, a lot of comorbidities. Those are a little more challenging.
Okay. All right, William, show us the twist of the case now, I guess.
Yeah, I didn't have a big twist for you all, but we did see she's a T3 and 0, and I apologize if the slides aren't best for that. I agree, she's like a T3.5, not 4, but we also had our radiation oncologist measure her tumor volume, which is about 15 cc's. She was entered to our tumor board, and again, like everybody's kind of commented, with recommendations for total laryngectomy, bilateral neck dissections. This patient initially was very hesitant for surgery, of course, doesn't want her larynx out. And so we kind of talked about the idea of why not considering chemorads. And I think looking at our NCCN guidelines, with her being a T3, slightly bigger, it is technically an option. And looking at the historical studies at the VA studying RTOG 9111, both showing promise for organ preservation, it's led, as everybody's kind of alluded to, more chemo rads for these advanced laryngeal tumors. But wanted to point out this this study on looking at advanced laryngeal cancer and evidence-based review. I think they really did a good job at looking at all the factors that have kind of been discussed in terms of bulky disease with larger tumor volume and survival rates going down with more and more chemo rads within North America. And so one of the comments I liked was this landmark trials did not show treatment superiority, but only offered options for preservation as a standard of care, and not all advanced laryngeal cancers responded to chemo rads the same.
Okay.
And I just had a few more slides on that in terms of tumor bulk, and the T3 laryngeal tumors decrease their radiosensitivity with increasing tumor volume. They've done some studies looking at cutoffs for tumor volume, which this lady obviously was not a candidate for, with volumes of 2.5 or 5 cc's, cutoff rates improving survival. So T3 tumors with lower volumes are great with organ preservation, but those higher volume ones like this one are better served with primary total laryngectomy.
Right. So what did you decide for this case?
She is getting a laryngectomy on Tuesday. She, much like everybody else has alluded to, debated it, signed up for it, decided to cancel, came back and saw me again. And after a couple conversations with our speech language pathologist and myself, has decided that she doesn't like having a trach, and she understands that her larynx isn't going to be functional without it, with rads. So
Can I add something to all that too, if you don't mind?
please.
Absolutely.
So I would argue, I mean, I didn't see the whole CT scan, Zoom, blah, blah, blah. I would argue that's not a T3, that's a T4. And then the point that you've made on the papers you just reviewed, it doesn't take a genius to figure out there's a huge difference between this tumor, whether it's T3 or not, and a T3 that's T3 because it has a 2 millimeter focus of cancer in the CA joint. Those are both T3s, right? You've got a fixed arytenoid in one, this one's got a massive disease. And so again, you have to tailor your care to the patients. I think this patient's getting the right care, and then the 2 week or 3 week or 2 month delay for a total laryngectomy in this patient is worth it. She'll do better. It's the same laryngectomy now versus be in 2 weeks later. So
yeah.
One of the
Excellent
downsides
conversation.
of the total laryngectomy, of course, is nobody wants a hole in their neck.
yeah,
This patient's tracheostomy is never coming out if they have
Yeah.
non-surgical therapy.
that's a great point.
Absolutely. And really, the other thing that I would just add to this excellent conversation is, in reality, this patient would be a very poor candidate for any chemotherapy with that much of a disease. I mean, good luck trying to do high dose cisplatin. Okay, fantastic case. That was great starter. Thank you. We have our next presenter, Jeff. Who's next?
It's going to be Andres.
Okay, Andres. Dr. Andres Baer. And I see Dr. Gilbert just logged in. Ralph, thank you so much and welcome.
Thanks, Patrick.
Okay. Andres, the floor is yours.
Are you seeing my slides okay?
Yes.
Okay, great. Well, I'm Andres Burr. I'm a head and neck surgeon at the University of Kansas Medical Center, and I'm going to be presenting another case here. So we have a 61-year-old male who's presenting with the chief complaint of globus, as well as some hoarseness, who's referred by a community otolaryngologist after finding a laryngeal mass on flexible laryngoscopy. He has a history of type 2 diabetes, hypertension, CAD, and doesn't have any significant past surgical history. No allergies, no relevant meds to the story here. He is a 1.5 pack per day smoker for 25 years. Typical story, quit 3 days ago. He does have a history of opiate abuse, and he is on maintenance methadone. On review of systems, he also has some otalgia on the right side, some mild dysphagia, and about a 10-pound weight loss over the last several months. Physical exam demonstrates a rough, strained voice, but he's breathing comfortably. He has no masses of the oral cavity and no lymphadenopathy. So we went ahead and performed a flexible laryngoscopy, and unfortunately I don't have a video of this, but we'll have some pictures a little bit later here. And flexible laryngoscopy demonstrated a large ulcerated mass centered on the laryngeal surface of the epiglottis, extending onto bilateral AE folds. And it extends into the right ventricle, possibly involving the anterior right true vocal cord. So this gentleman came with a CT, which I'll just play through here.
Okay. All right. Obviously, another tiny little tumor. You can't even see it now. All right. Well, I guess tonight is the big tumor night. It's like in preparation for Halloween. Okay. Do you have?
Can you hit play on that video again?
Absolutely.
Thanks.
And so, do you have an endoscopic image on this?
So I do. We also got him a PET CT, which shows the primary tumor is quite obvious, and there was some mildly hypermetabolic level 2A nodes, one on each side. And then, so I'll skip over that. So I took him for a direct laryngoscopy with biopsy. And you can see these aren't great images, but I was kind of focusing on that true vocal fold, which shows tumor extending into the ventricle, but not involving the vocal cord there.
Okay, so the vocal cords are okay.
Correct.
And this is a supraglottic, you would say?
This is a supraglottic tumor, yes. So, back to the discussion that you had in the last case. One of the questions that often comes up in our tumor boards is, is there cartilage invasion? This is clearly not a T4 tumor. We did not see cartilage through and through cartilage invasion on the CT. But our neuroradiologists do typically recommend an MRI to better assess. And so this was an MRI. Unfortunately, there was quite a bit of motion artifact, but our neuroradiologist commented on intimate lesional association and intrinsic T2 hyperintensity and probable enhancement of the left thyroid cartilage.
Okay. So Dr. Henney, looks like the glottis is not involved, but obviously bulky supraglottic tumor. How would you approach these folks? If you give us some pearls.
Great case, Andres. Thanks
Thanks.
for the presentation. That's Kansas City's my old stopping ground. It's complicated multidisciplinary discussion. I agree that it looked like there was a pathologic node on each side in level 1 in the very first slice of your CT scan, level 2, sorry. On the first slice of the CT scan you explained. It's likely, given the relative youth, 61, the fact that this guy is no longer smoking currently, that both cricoretinoid joints are uninvolved, and even both true cords seem to be uninvolved on your exam here. It's pretty likely this guy would be offered either non-surgical treatment or a conservation laryngeal operation done endoscopically with bilateral neck dissections. And that's probably what would happen here. That operation would be done with laser and not with robot, and would very likely not have tracheostomy associated.
And you would do that in one session, endoscopic plus neck.
Yeah, one anesthetic.
Question for the group: would you guys consider routine HPV testing for supraglottic tumors in this day and age?
It's routine, but probably not too important.
Okay.
Yeah, I think I agree.
Yeah.
We get it because we want the information, but we don't really know what it means yet with regard to the larynx.
Would you, so endoscopic approach, would you consider the old-fashioned supragallic laryngectomy, the open one?
I haven't done that in more than 10 years because you can pretty much always get this done transorally, but I wouldn't fault anyone for doing that.
What about the cartilage invasion?
I'd take the cartilage out.
Just go extralaryngeal with the resection?
Yes. So I should have teed up a video of just this operation. So at the time of the supraglottic laryngectomy, you can peel the tumor off with the perichondrium, and I'd ask the pathologist to tell me if there's tumor in the perichondrium or not. If that's clear, you can consider leaving the bone, and in an unradiated person, it will heal. Anytime you expose bone in a radiated person, that bone's coming out. Either you're taking it out today, or it's going to smell and stink, and the patient will cough it out in pieces, or you'll be going back and taking out granulomas with dead bone in them. But this patient hasn't been treated yet. If you find that there's tumor in the perichondrium or even in the bone, I would simply cut that piece of bone out, and the extra laryngeal surface of that thyroid lamina would be your final margin on permanent.
What about
Great
adjuvant
point.
and that with that approach, Mike?
I'm sorry?
Adjuvant treatment. Patients got bilateral nodes.
It's-
Let's say they have some ECS.
I think it's, yeah. So the study that multi-institutional study we did on transoral surgery for advanced laryngeal cancers is sort of the fourth arm of RTOG 9111, showed equivalent results and better laryngeal function and more larynges preserved. And only a third of the people got radiated. So it's not a guarantee, but we're looking at radiographic evidence where adjuvant treatment is probably going to be recommended.
And you're
Dr. Diaz.
I'll just point out, anytime you take bone out, whether it's part of the cricoid or you get through the cricothyroid membrane, or you take some laryngeal bone out and expose strap muscles, once in a while, the patient will develop a lot of sub-Q air post-op. And I've rarely had to put in tracheostomies to externalize the lungs to deal with that.
Babak, can I just add one sort of
Sure.
that hasn't been discussed? So, I think if you were to present this case in Milan to Giuseppe Spriano, they'd be pretty keen to do a supracricoid on this patient as an option for those that are attending this tumor board. So in Europe, so in Spain and in Italy, maybe in France, this patient would be offered either organ preserving non-surgical therapy or a supracricoid.
Open.
Yeah.
Yes, absolutely.
Yeah.
Dr. Diaz, what's the Anderson approach way?
So first of all, I think Dr. Henney's approach is a good one. We tend not to do that at Anderson. A couple of reasons, not the least of which is, while I agree with basically everything you said, Mike, I'm a little worried about this patient's need for post-op. And we just are a little bit, we like surgery up front when we think that's all they're going to need. If the chances of them needing post-op are higher, whatever that is, we tend to avoid that. So at Anderson, we would really rely on two main approaches. One would be standard of care. Chemo RT for this patient would be very effective. The other option would be investigational. We've got a study right now which uses immunochemotherapy for laryngeal preservation. These patients get immunochemotherapy up front. If they get a complete response after 3 cycles, that's all they get.
Wow.
And I think we've enrolled 16 patients, and I think 14 of the patients have been complete responses. And we've got follow-up now after about 1.5 years. So that's the experimental stuff we would offer. Now, we think that's a safe approach because if it doesn't work, then they still get offered standard of care. And if they recur, they still have standard of care and can be salvaged later. And then as far as if I'm going to do operate on this patient up front, I have nowhere near the experience with the laser that Mike has. But at Anderson, if we were doing surgery on this patient, they'd get a supracricoid. They would get a supracricoid with CHP. if we're doing surgery, but we probably would not use surgery up front on this patient.
Dr. Gilbert, what's the Toronto approach?
I think I pretty much described it. We would not consider transoral laser for this procedure. And my biggest concern here is the paraglottic space. This tumor is in the paraglottic space based on that CAT scan. So it's heading towards being a transglottic tumor. So that would make us pretty gun shy. But at PMH, this patient would definitely be offered chemoradiation without a doubt. But if the patient wanted surgery, for me, this would be a super cricoid. I wouldn't do it endoscopically.
Yeah, great.
Well, I guess,
yeah. Andres, in one case, you showed the entire gamut of laryngeal surgery from 3 different experts. Fantastic. Congratulations. All right, go ahead. You have about 7 minutes to finish this case.
Okay, sounds good. So just a brief. So this is T3, clinically N0 or N2C, sort of equivocal nodes. So I offered the patient surgery or non-surgical treatment. He met with our medical and radiation oncology teams to discuss different options, and ultimately elected to proceed with a surgical approach. And so what I did for him was a supracricoid partial laryngectomy. So here you can see some intraoperative photos. We're able to preserve both cricoarytenoid units. You can see the specimen there on the right. My concern with a supraglottic laryngectomy was just the fact that I didn't believe I could get much of a margin at the true vocal cords. It was really filling the ventricle and abutting the cords. So this was and then of course the cricohyoidopexy. So pathology showed squamous cell carcinoma involving supraglottic larynx with invasion of epiglottic cartilage, preepiglottic and paraglottic spaces. The closest margin was 2 millimeters at that left arytenoid. He did end up having 2 lymph nodes, so one in each side of the neck in level 2. There were very small metastases. The largest was 12 millimeters. The other one was less than a millimeter focus. And there was no extranodal extension in either node here. So final staging, pathologic staging was T3 N2C. And so, go ahead.
Can you mind just commenting on maybe the conversation you had with the patient leading up to the surgery that,
Sure.
How do you don't always know exactly what you're going to get when you get in there. So
Right.
if you just sort of give some teaching points, that'd be great.
Yeah, absolutely. So I did discuss options with him. I actually tried to steer him toward non-surgical treatment. I tried to steer him toward chemoradiation. I referred him to our one of our radiation oncologists, as well as our medical oncologist. He met with both of them. One of the concerns, kind of on the backstory here, was just his, with his opiate history of opiate abuse. We're a little bit concerned about his ability to get through non-surgical treatment, and so I offered him laryngeal conservation surgery versus chemoradiation, and after making his way around, he elected for surgery. Mm-hmm. We discussed his laryngeal function was intact. So, unlike the first case that we discussed, it's really a very, very different approach and different story.
Do you discuss the possibility of a total laryngectomy and everything?
Absolutely. Okay. Yeah, absolutely. So, if I explained to him if I wasn't able to clear it, and that's something with any open resection, especially a supracricoid, I discussed the possibility of needing to do a total laryngectomy. And so he accepted that risk.
Yeah, Jeff, if I could add to that, I don't take a patient to the operating room for conservation laryngeal surgery, open conservation laryngeal surgery, without a possible total laryngectomy on the consent.
Yeah. So this patient declined radiotherapy. Dr. Hinney, and then we'll ask the group, and we have to finish this case. But how strongly do you push patients to have N2C disease, be it very low volume, to go ahead with radiation, or you say, okay, we can watch you?
Well, most of probably 90% of the folks in our practice here that get radiation get it because of the neck disease. And that comment is informed and perhaps biased by the HPV positive oropharynx cancers and all the escalating trials going on with that. Clearly this patient would be offered adjuvant radiotherapy with a N2C, and it's not unusual for patients to refuse it. I'm not sure with a single small node on each side and a thorough operation that I would, really push it. But it's clearly going to be in the record and it's going to be recommended. And the radiation oncologist and the surgeons would be on the same page with that. But Andres, I wanted to just compliment you. This is a great case. I think you did a great job. And while we're looking at this slide about a arytenoid tilting and sliding, do you want to comment about the importance of an air knot with supracricoid laryngectomies for those on the conference call that maybe don't do this operation?
Are you're referring to repositioning of the arytenoids?
Yes.
Yeah. So one of the crucial steps with this operation is really to try to reposition those arytenoids, because what will tend to happen if you don't place a stitch to try to reposition them anteriorly is that they'll fall backwards. And so then patients will be at high risk of aspiration and have extremely poor voice quality. So one of the really critical steps to maximize postoperative function is to place a suture and to place a suture with an air knot to try to reposition those arytenoids anteriorly so that they do make good contact with the base of tongue. Now, if you overdo it, then that patient's can be very difficult to decannulate. So you kind of have to find, in my experience and in training, you have to find the sweet spot to position those arytenoids such that they'll make good contact with the base of tongue on phonation, but provide an adequate airway at rest.
Right. So I have a question for Dr. Gilbert here. Go ahead.
Can I add something to that, what Andres just said? So
Absolutely.
Andres, not only are those air knots important to bring those arytenoids forward, but we talked about the impaction being a cricohyalopexy, but really, I think that if you put those stitches in right, they don't touch the hyoid. They go well up into the base of tongue, so that you pull the mass of that base of tongue down and backwards to give something for those arytenoids to hit. That's why you've got to be careful with those stitches. Make sure they're not too lateral, because if you're too lateral, you can bag the hypoglossal.
Right.
So 3 stitches right in the front for the impaction, and then those arytenoids pulled forward. That's a great result right there.
Great. So Dr. Gilbert, and please make your comment. And also, I was going to ask you, you're known to do a beautiful reconstruction when it comes to hemilaryngectomies. What are your thoughts in any reconstruction for supracricoid?
Yeah, so I think this is different. I think the best results are achieved with this approach. I don't think there is a reconstruction that suits this. In fact, if you try and do some type of tissue interposition here, you end up with a worse result in terms of function. So these patients, you need to maintain sensation of the tongue base. If you create any anatomic or sensory dead spaces at the base of the tongue, they've got big trouble with aspiration. Now, I had my hand up to ask a question, which was how long was he in hospital? How long was he trach dependent? And how long was he NG tube or G tube dependent in this case?
Yeah, great question. So he was in the hospital for 6 days. He did keep his trach for a while, but was able to start an oral diet at about 2 weeks. The trach was ultimately decannulated. It actually took about 8 weeks to get his trach out. But once we did, he continued to do well. And at last follow up he was about 20 months. There was no evidence of disease, and I've gotten a number of scans as well, just because of his NTC neck.
Yeah, obviously, those of us that have a big volume experience with supraglottic tumors, can parade out an array of patients who've had chemoradiation, or in some cases radiation alone, with arguably better results. So that's always a balance between, how you can treat the patient, what they're prepared to accept. And obviously in this case, in an opioid dependent patient, I think you probably made the right call that he probably would not show up for treatment, and he's best served by surgical management. But there's a lot of patients that have great results from non-surgical therapy for this particular tumor location.
Absolutely. And that's really the art of, treating not only the disease, but treating the patient. Okay, fantastic case. Thank you so much, Andres. And now we are going to have Jessica.
All right. Can you see it?
Yes.
Okay. So my name is Jessica Yasensky. I am originally from Chicago and came down to Indiana University, and really happy to be here tonight. I was going to talk about a hypopharyngeal cancer. So we had a patient, a 66-year-old gentleman who presented with a several-month history of several symptoms. Most prominent was his dysphagia, as well as some odynophagia, really just sort of this chronic sore throat, did endorse some right-sided otalgia, did have some episodes of hemoptysis. They were small volume, self-limited, tend to just have some blood within the saliva. He has a past medical history of hypertension. He has coronary artery disease. He had stents placed about 4 years ago, no longer on any blood thinners. He does have a 40-year pack smoking history, and like all the other patients, quit the day before he came into clinic. He does have a significant alcohol use history in the past, but nothing current. He did come in with a CT scan from the outside hospital, but on exam in the office, he was in no distress. He was able to voice, albeit hoarse, but still had a voice. He didn't have any stridor. On palpation, he was full in the right side of the base of tongue. He did have some firmness in the right neck along the right thyroid cartilage. The larynx itself was fully mobile, and he did have some right level 2 firm lymphadenopathy. So on a flexible exam, we don't have a video, but we have some pictures which showed a mass that appeared to be emanating from the right piriform sinus up to the area epiglottic folds. It was creeping down into the postcricoid space and up into the base of tongue on that side as well. His vocal cords were, his larynx was pushed off to the side, but his vocal cords were mobile bilaterally.
And there is no tumor in the endolarynx inside the epiglottis or around the glottis, correct?
Correct, exactly, correct.
Okay, great.
So we have some slices of his CT scan.
And both vocal cords are moving on, and the larynx is pushed to one side.
Correct, yes.
Okay, all right. Well, Dr. Diaz, the classic smoker drinker with a hypopharynx.
Yeah, I don't want to go first on this one.
Okay, fair enough.
I mean, that CT scan, I think, tells it all. That's the bad story. You've got, looks like erosion of the back half of the cartilage on the right side. It's a big hypopharyngeal tumor. I'm actually surprised his larynx still works fairly well. I'm guessing he's having some problems swallowing. Yeah, he's got a relatively smallish volume tumor we would treat with chemo RT or, some modality of chemo and radiation therapy. But I'd be very worried about this guy's function long term. This is a guy that might be offered induction chemotherapy in the attempt to see if you're, the old Michigan approach, see if they respond. If they respond well, then go to chemo radiation therapy. But I got to be honest with you, this guy would be a good candidate for total and a free flop and reconstruction.
Yeah. I have to say that after all these years, I have yet to see a good outcome with trying to do definitive chemo RT with hypopharynx, unless you go back and look at the tumor and for some reason with HPV positive. Okay, well, Dr. Hinney.
Well, I guess I'm firmly in the camp of Dr. Diaz and the MD Anderson. This is a big tumor. this is just to think through it, not a candidate for an endoscopic operation. When I first saw the photograph, I got a little excited, but it's been described as going down post-cricoid, which is not necessarily a deal breaker, but it's technically difficult. But looking at the CT scan, there's clearly a fair bit of bone involvement. If everybody could try to get on Amazon and find an old copy of John Kirchner's book where he whole sectioned dozens of larynges that had been removed for laryngeal cancer, demonstrating how they tend to spread outside the larynx through the posterior cricothyroid membrane. This could have been, the CT scan of one of Kirchner's specimens. I think at our institution, this patient would get a laryngopharyngectomy and a reconstruction,
And do well.
and bilateral neck dissections and adjuvant therapy to follow.
Yeah.
I'd
This tumor
remind
is
the
very
younger
unilateral.
doctors that the piriform sinus, I think of it as an inverted tetrahedron. So there's a posterior wall, a medial wall, and a lateral wall that then merge inferiorly into a point behind the cricoid. And looking at this, all three walls are involved, and any sort of operation for a piriform cancer of the medial wall also involves the larynx, because that's a shared wall, and the recovery from that is a bit tougher than the ones on the posterior or lateral wall. But this is a big tumor, and I think it'd be pretty much a no-brainer in our multidisciplinary committee to recommend either non-surgical treatment, or depending on all kinds of. I would. Tumor boards don't examine patients, and they're not responsible for the consequences of their recommendations. And the treating doctor, whatever type of oncologist they are, who's made a relationship with the patient and their family, in my view, should carry some extra sway. So I never like to kind of be really dogmatic about, oh, you have to do this based on this CT scan on this patient I've never examined or spoken with. But I just in general would expect, like Ed, we would recommend a laryngectomy and a pharyngectomy and a flap.
Okay. Dr. Gilbert, how would this patient be treated at Toronto, and how would you approach the tumor extirpation and the reconstruction?
So I wouldn't disagree with the recommendations. I would disagree with something you said, Babak. I would never disagree with you, but on this one I will. There's small volume, particular locations of hypopharynx cancers with small volume nodal disease that do well with non-surgical therapy. And so I don't think what you said, like unless they're HPV, they don't do well. I think there's a couple of nuances to this case, which are, first of all, that tongue base involvement is very concerning. These tumors extend superiorly. It's both technically challenging surgically because of the extent of disease that extends up in the peripharyngeal space. But in our institution, this patient would be advised to have primary surgical management with adjuvant chemoradiation. Reconstructive approach would be dependent on the extent of the residual mucosa. Without seeing all the imaging and scoping the patient, I suspect this is going to be close to circumferential. And if that's what it ends up being, if his body habitus was appropriate, we would do a tube thigh like everybody else would. We would consider a gastromental if he was a salvage case.
Mm-hmm. Great. Yes, I completely agree. Those T1, T2 hypopharynx, especially when you work at VA, are hard to come by, but you're absolutely right. Susan, what would you do in Alabama?
Exactly the same thing. Surgery with adjuvant treatment, laryngopharyngectomy, flap, adjuvant.
Okay, so I think all the audience noticed that there is not really a huge enthusiasm for trying to do organ preservation here, especially when it comes to large, relatively extensive hypopharynx. Okay, Jessica, tell us what you decided.
Can I just comment philosophically about this? Yeah, sorry.
Yeah.
You know, one of the things for the fellows on the call and less experienced faculty, the thing to remember about hypopharynx cancer is, you know, look at the survival curves on these patients that have extralaryngeal disease and extensive nodal disease. You know, probably the best results are maybe 20% of these patients are alive at 2 to 3 years. And so you're really doing a palliative approach in these patients. And so anything that can maintain swallowing and get them back to enjoying some quality of life is good treatment. You're gonna, you know, have some miracle cases, but it's not very many.
Yeah.
This is different from supraglottic.
Yeah.
Jessica, before we get to what you did, could you run through the scans again, or the photograph? Because I guess I didn't see the tongue base involvement. The lingual tonsil on the picture looked normal to me on that top picture.
You mentioned area epiglottis.
It's coming up into the tongue base, and you described the tongue base was firm on exam.
Correct. Yes. Yeah. Firm on exam. Yeah. Yeah. And
Well, I
yeah.
see it in the pharyngoepiglottic fold right there, but the lingual tonsil looked normal. So I just, anyway,
Yeah.
go ahead.
Yeah. Sorry.
There was
Not the best picture for it.
Before you move on, there was a
Okay.
question from the audience. Can the panel comment on the central compartment as part of the management for this disease? Whether you would do a formal central compartment in all these cases when it's hypopharyngeal? I think it was the question.
I would.
You mean central compartment neck dissection?
Yeah, so besides the lateral compartments, do you address the central compartment for these
I mean-
hypopharyngeal cancers routinely? Both sides, one side?
You know,
Come on, you were there already.
we would so this patient would get, you know, carotids in on the left side, a more formal complete modified radical on the right side. And it's hard to do a total laryngectomy, partial pharyngectomy without doing the central compartment.
Yeah.
I mean, you're there.
That is the central compartment.
Yeah, I mean, I mean, you can really dissect really hard to dissect off the stuff on the right side, but I really don't see the benefit of why you would do that. So, yeah, no, it comes out.
I agree.
All patients need is just one parathyroid. That's all they need. Okay.
Yeah, I think the other question, Babak, is how low do you go? I think that's part of the question. Yeah. Some people sort of advocate extreme dissections into the central mediastinum, and you need to be a little careful with that in terms of tracheal vascularity, maybe with an extended pharyngectomy as well.
Great point. How low do you go, Dr. Gilbert, in these cases?
I mean, I would go as low as I routinely go in a thyroid with central compartment. It depends a bit on what you find too, and a bit on the staging as well. So if the imaging, you know, shows disease in the paratracheal area, the patient's in serious trouble, I would, you know, obviously dissect that area. We consider it, treat it in the adjuvant space as well, but I don't push it too hard personally.
Yeah. Okay.
Yep.
I guess I hope everybody pay attention to all these discussions, but I'm learning a ton here. All right, Jessica.
Yes, so the patient underwent a total laryngopharyngectomy with bilateral neck dissection and a tubed ALT flap. He ended up being stages a T4A and 2B tumor, and he underwent adjuvant chemo-RT. And he actually, this patient was from 2013, and he actually, as of 2019, was cancer-free and alive, tolerating a PO diet.
Right.
What was the indication for adjuvant chemo-RT? Was it E&E or something else?
I would have to double check what the chemo, what the indication for chemo was, but he did receive chemo-RT.
Fantastic.
Yeah, I'll bet you had a lot of extralaryngeal spread. We'd give chemo-RT for that as well.
Great. Well, fantastic discussion. We have 3 minutes, so I'm not going to let the panel go. Any last comments regarding, Dr. Henney, we'll start with you. In terms of how do you approach patients and any consult the patient and assess tumors, endoscopic versus open?
Well, if your question is how do you counsel them about endoscopic versus open conservation surgery?
Correct.
Then we have a heavy institutional bias toward endoscopic or transoral surgery. The hospital stay is dramatically less. They can start swallowing earlier. For example, if you endoscopically sever the superior laryngeal nerve, it's not buried in an external closure, and those patients probably get some sensory function back, as Clarence Sasaki suggested. They don't get tracheostomies. So that it's just a much less morbid treatment if you have the patience, would be really critical to be thorough and absolutely clear the margins. And you absolutely have to have a really interested pathology team.
Yes, that I would completely agree that the margin is always the bane of our existence sometimes. And you know that you have taken the tumor out, but it's not proven. Dr. Diaz, what's coming down the pipeline for a laryngeal treatment, and any particular trial that you are excited about?
Yeah, so let me answer a question. Someone just asked about do we use salivary bypass tubes for tube flaps if patients leaking? I can't remember using a salivary bypass tube by our head and neck surgeons. I mean the reconstructive surgeons. So they're rare. We usually just pack the wound; it'll close eventually. The big excitement for me, I got out of big time research for a bunch of years while I was in administration, but in the early aughts, we were doing a lot of stuff for exclusive chemotherapy for select laryngeal cancer patients, and based on that results, and now with the onset of new immunotherapy regimens, we're approaching that again. So I alluded to that earlier. I've always thought that taking out a person's larynx is a horrible thing to do. It's a great option in many cases, but it's still a horrible thing to do. And I really do think that immunochemotherapy is the future. And the results we're getting, when we did this study back with using taxylifosfamide and platinum back in 2000, and this is what we expected. We thought we would get about a 30% CR rate, and then we'd get some recurrences. They'd have to get radiation therapy or whatever. But ultimately, 30% of laryngeal cancer patients, not T4s, would be able to treat with chemotherapy only. And that's proven true. We've been able to continue that. Now, using imiplimab in addition to carbo, now we're getting response rates that are just out of this world. I mean, essentially 100% response rates, and a complete response rate of, I think it's 86%. We've had one recurrence out of those 16 patients, not recurrence, but the patient that ended up getting a more traditional definitive radiation therapy. So that's the future as far as I'm concerned. Immunochemotherapy. It's amazing what they do with those things now.
Fantastic. Dr. Gilbert, a couple of questions for you as well. In terms of salivary bypass tubes, when you do a extensive reconstruction of neopharynx, what's your approach in that? And then what gets you excited about laryngeal reconstruction?
Well, in terms of salivary bypass tubes, Babak, we've published on this. I think you were involved in the publication. Our approach in circumferential defects is always to use them. And our rationale for using them is not to prevent leaks, but to prevent strictures. There is an issue in selected patients, particularly salvage patients who chemoradiated. If you leave the tube in too long, they can cause a secondary problem. And if you think that's happening, usually what you'll see is the fistula will start getting bigger, and that's when we consider taking them out and surgically diverting them. But it's relatively infrequent. I think in the reconstructive space, I think, as Ed really just described, the big thing is patient selection for treatment so that we don't need to operate on patients with advanced disease. And I think what we're finding over time as we adopt more translaryngeal procedures that Mike described, fewer and fewer patients need salvage reconstructions. But don't forget, there are patients that fail chemoradiation, some of them treated for early stage disease, who can be salvaged without total laryngectomy if you think outside the box in terms of the reconstructive options.
Right. Okay, well, I'm gonna thank you so much. I'm gonna give the last word to Madam Secretary. Susan, taking out somebody's larynx is not an easy conversation. Give us a few pearls. How do you counsel the patient?
I think that my conversations are really informed by my experience with patients who have had laryngectomies and done just incredibly well, especially, in the early days when patients might have a laryngectomy and not have to have radiation. Their function is amazing. Their quality of life is really good. I really rely a lot on the quality of life data showing that people who look at me first and say, absolutely not, I would rather be dead, I will never have a laryngectomy. And then those who go through with it and a year later, their quality of life is as good or better. So I try to share that with patients, and then I just try to walk with them in terms of, adjusting to the change in body image that they're facing. Honestly, like Dr. Gilbert said, I think neck breathing is so stigmatized in our society, and yet people acclimate incredibly well. But I also agree with Dr. Diaz. Nobody wants to take a larynx out. It's an amputation that no one wants, but it can be lived with.
Yeah, I think that's one of the supreme ironies of head and neck surgery. One of the most effective oncologic treatments, the one we have, is the one that nobody wants to have. All right, great. This was an absolutely phenomenal session. Thank you so much, Dr. Diaz, Dr. Henny, Dr. Gilbert, and Dr. McCammon for joining us. I learned a ton. You saw the full gamut of laryngeal disease and discussions. Next time, hopefully, we'll have some kind of a little smaller tumor that we could discuss more laryngeal preservation surgery. Please join us for our next session, December 1st, advanced metastatic squamous cell carcinoma of skin, with all the hot new stuff. Thank you so much, the panel, all the fellows. Have a great time. The next session would be the last session for 2021. Have a great time. Happy Thanksgiving ahead of time to you guys. Take care.
Thanks, Babak.
So good to see everyone. Thanks, Babak.
Well done, guys. Take care. Bye-bye.